So one of the first questions is, in your particular field, and the field is the field of public health, Professor Heimer, addiction medicine, Dr. Hawk, the field of public health, I guess, our director, Byron Kennedy, Dr. Kennedy, and police and security is Chief Campbell, and of course Mark Jenkins in the Greater Hartford Harm Reduction Coalition, which is, I guess the best term would be informed community activism to respond to public health challenges. So we have a variety of allied but different fields. So in thinking about drug overdose and the year 2018, what is the field? And I guess we can maybe go in reverse order, and we'll let the chief settle down and just have Robert Heimer give a sense of where are we with overdose, and he might want to comment on what happened here in town on August 15th.
Well, thank you. Thank you. Actually, I wasn't in town when it happened on August 15th, so I'm going to let Dr. Hawk, Catherine, respond to that since she was doing all of responding at the time. But I do want to point out that what happened on the Green should best be characterized not as an overdose, but as a series of poisonings. And the difference, I think, is a fundamental one, that people who were seeking opiates and who overdosed because the doses are higher than they expect, got the drug they wanted and just took too much of it. I don't think that the people who took this synthetic cannabinoid on the Green really wanted to experience whatever it was they experienced, the catalepsy, the catatonia that occurred. I think that we do need to differentiate between those two, just from the standpoint of how we frame our response. Because when it comes to opioid overdoses, I think we should focus on, because they are killing, more than 1,000 people in this state this year. It keeps going up every year. It is a massive public health crisis of national, national importance. Our response as a academic community has mostly just been to report on it. There have been several attempts to demonstrate that getting naloxone, the antidote to opiates, into the field has been very successful when people have access, when people are using drugs in groups of people and somebody has an overdose and falls out, that the people who are trained, even if they're lay people, can respond as well as emergency medical service people or people in the emergency department. There's no question about that. The question is getting this drug into the hands of people who are even before the first responders, police, fire, EMS, they are really the first responders. And we also need then to encourage drug users to use drugs with other people if we're going to save lives. Don't go into the bathroom and lock the door. And we've been trying to do that, and we continue to try to do that. The first community naloxone distribution began almost 20 years ago with the Chicago Recovery Alliance, and its founder and CEO until he died prematurely last week, Dan Big, and he should be remembered for really being the founder of community-based naloxone. And we've been working on trying to explain how well this works when it's scaled up, if we can get enough naloxone into the community. And Mark can talk about this because he does this with incredible skill in Hartford.
And although I certainly identify as an addiction medicine physician, I'm also an emergency physician, for those of you who don't know me. And so I actually want to take it back a little bit, and it is really important what happened a couple weeks ago to talk about that, but I'd also like to talk about sort of, the question is kind of what was your field's response to overdose and increasing overdoses that we're seeing? And I think emergency medicine has really, I think, sort of changed the way that they kind of interact and view the scope of the problem and the response to the problem. And so it's actually been really sort of invigorating to see over the last several years, many of my emergency medicine colleagues kind of identifying, being more upfront about identifying, patients with opioid use disorder, being willing to link patients to treatment, and really kind of taking an active role in trying to identify how we can effectively get people into evidence-based treatment. And by that I mean treatment with methadone and buprenorphine. And so that's been one of the, I think, the things that is still certainly evolving in my field of emergency medicine, and access to that has certainly been there in addiction medicine. But really it's about kind of expanding support and access to that and our ability to talk about how these medications work to our communities.
And then, a couple of weeks ago, when I actually, first heard about this, I actually got a call from our lead for the city, Rick Montana, about what was going on that morning. Shortly after that, I actually ended up receiving a email, maybe from the dean, who had actually had been in communication with a couple of his, faculty who had observed what was going on. And so, to that extent, late in subsequent conversations with Rick Montana, one of the concerns that we actually had was just the potential use of opioid use. And then as a result of that, being able to have readily available, Narcan, and to actually use that. Although when they were utilizing that in the field, it became pretty clear, that they didn't necessarily suspect that it was opioid based upon the lack of response to the Narcan. That being said, when you actually have individuals, that you need to respond to fairly quickly, you don't know that in advance, and yet, so you still have to take those particular steps, including using Narcan, which for us, that actually depleted a large bar of supply that we had. And so then consequently, it was in subsequent conversations with the state DPH, specifically Commissioner Pino. And then along those lines, having some conversations with him about seeing what Narcan was available they could provide to the state, which they did, so we were really thankful for that. And they actually got that here pretty promptly, similar to what they actually had done, a couple summers ago. And we actually had, some similar events, but those actually involved fentanyl. So I think, being able to respond fairly quickly and then also being able to deploy the resources that you actually need at the time is probably critical. And I think certainly Police Chief Campbell can speak more to that in terms of this could have been much worse.
Things were a little different, again, from the Hartford side, and again, responding to what happened on the drain. But we kind of knew early on that these were, it wasn't, although we had to wait for the forensics to say it wasn't opioid, from afar it was like, okay, I kind of knew what the culprit was, because it's happened in various other cities. In response to what we've been doing from Greater Hartford in relation to making sure naloxone is available, we've been, first off, one of the only, if not the only, community-based organization in the state for the past 2 years that's done an overdose prevention education every week for the past 2 years and make sure that naloxone is given out free. We also understand that intravenous drug users are not adverse to an intramuscular dose of naloxone, and it's nationally the best practice for administering, for being able to have a sustainable supply, but unfortunately, not everybody's comfortable with that. However, we were able to be on hand. As a matter of fact, we gave approximately 700 doses to people here in New Haven for, to be dispersed. And we for every dose of nasal Narcan that is given out, we can purchase 10 times as many kits. And so we need to be able to keep the medication available for those who are averse to that. If, I guess that's our message, if anything right now, is for like our fellow SSP providers and for agencies and organizations that deal hands-on with the population. Let's go for a more sustainable method, because as we said, when in doubt, it needs to be used. But if we use up all of those supplies that are on hand, what do we do? So we really have to go with a more sustainable model. And
Good afternoon. When it comes to our particular field of law enforcement's response to the drug overdoses, it really started well before the green for us. Back last year in 2016, the summer, we had 20 overdoses of opioids. People were buying what they thought was heroin. It was straight fentanyl. 20 people overdosed. We lost 3 of those people. As a result of that, we had to change the way we respond. Typically, when it comes to law enforcement, the fire department and police department are dispatched from the same room in the police department. If an overdose were to come in, that's not a police issue. That's a public health issue. Fire department typically would respond. So we weren't responding, but after these 20 overdoses where we lost 3 people, we changed our policy so that anytime an overdose is called in, officers are now dispatched to that overdose so that we could gather any evidence including any drugs that are left over, cell phones, etc., so that we could start an investigation. Fortunately, we were able to do a great investigation with the 20 overdoses, and we were able to apprehend the subject who sold this bad batch to people on the street, and the individual was convicted. As a result of that, we also started training our officers differently with respect to issuing them gloves, some respirators, because one of the major issues from a law enforcement standpoint is even when you're going to do large-scale busts, a lot of times if there are weapons inside, we would throw in what we call flashbangs, and that can make any fentanyl or drugs inside become airborne, or aerosolize them, and that then can take the officers out, which we've seen happen twice now up in Harvard. So training has been a major change. And when we look at the green, I think that a big reason the green wasn't as bad as it could have been is because we had started these progressive changes in how we respond from a law enforcement standpoint. We coordinate with the fire department, with AMR, so that when we see overdoses start scaling up, we immediately have a plan that is put in action. Sorry for being a little late, but we had 3 overdoses on the green as I was on the way up here, so we had to start a process of scaling up. And I think it is that process of seeing the trend, seeing and getting the reporting immediately, having our intelligence unit out there right away to find out where did the people get this? Is there a particular dealer, or is there something going on? Is this a particular bad batch? Really has helped us with our response. And so one of the major changes is each situation you learn from. You learn, like we were able to make an arrest within 4 to 5 hours of the individual, get a second individual in a hotel room who still had 30 bags on them, find out exactly who the individual was who gave this to them, where they got their distribution from, and where it was coming from, which was outside the city. So quick response as quickly as possible. And I think the biggest change for us is also in the mentality of understanding that we are not looking to criminalize the victims. One of the biggest things during the interviews during the green situation was reporters kept asking, why are these people who have overdosed, why are they not being arrested? Because they're victims. They're victims, and I'm glad that you pointed out, they're not victims of overdosing, they're victims who were poisoned. Poisoned because this is a substance that many of them took one hit from and were laid out. So it's important that our response in getting the message out to the community that these are people who are being preyed upon, they're victims, they have substance abuse disorders, that we're not going to arrest our way out of this situation. We have to focus on those who are distributing it, make the arrest there, but not with the victims.
Thank you. A.J. Aiken from the Connecticut Community for Addiction Recovery.
Hey, my name is TJ, and I'm a young person in recovery. And for me, that means I haven't had a drink or a drug since July 9th of 2016. What I do is I'm currently an emergency department recovery coach with the Connecticut Community for Addiction Recovery. And I apologize for being late. I was actually working with an overdose patient like 45 minutes ago, and working on some stuff, and trying to get him to his pathway that he chose. He wanted to get treatment at a shop because he'd never been to inpatient treatment. What is my field's first response? So what we do is we go into emergency rooms and provide recovery support services, not addiction services. So once a person goes to the emergency room and asks for help with substance use disorder, or they present with substance use disorder, we then ask them, or then the hospital staff will ask them if they would like to speak to a recovery coach. At that point, recovery is initiated in their life, and we come in and we go in and help them get the needs of their recovery met, whatever that means will be. The main thing is meeting people where they're at, and what we do is, I'm not a clinician. I'm actually grateful to not be in a clinical-based role in this, because what we do is we treat people as a resource, right? As a resource to their own recovery, help them figure out what they want to do. What we do is we ask good questions, we manage and discover our own stuff, and we actively listen. Through that, we can then help people pick out their recovery-oriented plan, which them having chosen their plan, they're like 10 times more likely to follow through on said plan and make said plan work for them. You know, it's not the 1980s anymore. It's not here's an NA book, don't get high and go to meetings, you know. Obviously, if that had worked, you probably wouldn't be sitting up here having this discussion with the public, right? So there's many pathways to recovery, and we embrace them all. So everybody's recovery process is going to look like a lot different than that. So what we do is, my boss calls it laying the buffet out. So we help them fix or choose from options that would fit good for their schedule. Most people, we work with our parents, you know, it's not just an inner city problem, it's an everywhere problem, and it's not just opiates. So America has been in this addiction crisis since long before I was even born. It's just opiates are causing people to lose their life in a more rapid sense. I think 1 in 10 people in the emergency room presents with an alcohol-related issue, and yeah, I don't like to say the word service, but we work with anybody from alcohol, cocaine, TCP, marijuana, whatever that substance of use, not substance of choice, because you know the addiction being a disease, right? They wouldn't choose to use these substances. That would be the substance that they would use. And meet people where we're at. We also have recovery community centers, which are amazing places where they provide recovery support services to help people continue and sustain recovery. We provide free recovery coach training, as well as many other collaborative things. It's a great way to engage in the recovery community. I got sober going there. There's many options to recover. We help present those with all recovery meetings. So it's a non-denominational based meeting where people can come in and not be fearing of what they've previously thought about recovery. And pretty much I'll pass it back out to that before I get going.
All right, excellent, thank you very much. The second series of student questions has to do with the kinds of collaborations that are necessary to provide integrated services to persons experiencing substance use disorders. And another way of sort of expanding on that is, how do we break down silos between organizations or fields so that entities that have previously not done a particularly good job communicating can help solve these issues? So again, the kinds of collaborations needed, and how have we been successful or less than successful at breaking down barriers across entities to solve those problems. So this is the collaboration question. Now I want to say that we have enough space in the auditorium for everybody who's standing, that you have to get up and get down here in the front and ask sit in the middle somewhere and just make yourselves comfortable. So feel free to do that as the answers are coming. And I guess, TJ, we had you ending, but do you want to start this time and talk about collaboration, breaking down barriers? Now, if some of the panelists hear the points they would have made, having been made by a previous panelist, you can just pass the mic and we'll regain a little bit of time.
Yeah, absolutely. Collaboration is important. One of the main goals of a recovery coach is to remove barriers for people. There can be a lot of obstacles in people achieving recovery, right? So what we do is we work with people, and there's this great thing called the Hope Initiative, and it's currently in Manchester, and it's working to be in Willimantic. I don't know if I'm even supposed to say that, but I don't know. It's out there. So people would then present to a police department, and as opposed to being arrested or fined, the police would then help them get into treatment in Manchester. What exactly happened was they would drop people off at the emergency room. Well, what typically happens at an emergency room is you get a schedule book for AA, and all of the numbers in the phone, and they say start calling. Treatment is not the option for everyone. Treatment is not the option for everybody seeking recovery. So everybody's pathway to recovery being different. Some people find hope, love, guidance, mentorship in 12-step fellowship, and some people find that through outpatient, inpatient, many different ways. Some people go to the community center. Some people go to wherever. So helping that person identify that. Also, going into that, we also work with a lot of other organizations. So like CPAR in Willimantic is a resource haven for people. So we have connections with a lot of the outpatient therapy, a lot of the medication-assisted treatment places or medication-assisted recovery places all around. We are working, there's a lot of places when we work with hospitals, they're starting to do Suboxone induction in the emergency room. So people would then get offered the opportunity to start Suboxone within 12 hours of an overdose. They can then continue that with an outside provider, and outside providers do one-on-one therapy, group therapy, regulated urine checks to help people stay accountable. What we do is we collaborate. So I also work with families as well. So like I coach families because typically somebody brought to the emergency room for substance use disorder is not going to be alone. Some people, they roll through by themselves, but other people are connected and they still got family support, and they go on, we coach the families on how to support them and engage them, and there's many ways to collaborate with the community. If you think about it, so everybody thinks a lot of the answer is treatment, right? So we send somebody to treatment, you send your loved one to treatment, boom, 90 days, 30 days, they're fixed, right? And they're back out in public. At that point, people are at a 5 times, 10 times the risk for an overdose where we run into these problems. So helping the people find something that exactly works for them and engaging in supports afterwards. That's the main thing, is engaging in community-based supports afterwards. One of the many ways out of addiction is connection. And connection to our fellows, connection to other people in recovery, and connection to community, whether it be the recovery community or the other community. People need purpose in their life, and our goal is to give that to them. Thank you.
I think one thing that TJ touched on is where I'll start with collaboration. He said that one thing they will do is if a person has overdosed, they will come in and offer them a pathway to recovery. And I think that type of collaboration is something that we learned from the Green. I was out there when the bulk of the overdoses were happening, and after about 4 or 5 hours, one of the things I found the most frustrating was people started overdosing, and when I looked, they had their wristband from Yale New Haven Hospital or St. Raphael's Hospital. They had been on the Green, overdosed, been transported, treated, released, and were back on the Green overdosing for the second or third time. So the type of collaboration where you can have someone in the ER, in the hospital, wherever it is that they've been transported to, that give them, as you said, the buffet, some options of a different path rather than going back to exactly what they just came from is crucial. And I think collaboration is critical in all of us breaking this cycle. This is not a law enforcement issue per se only. It is all of us working together. It is us working with the churches, both on the green and throughout the city. It is us working with substance abuse providers. In our city in particular, New Haven experiences some unique situations because we have a number of drug treatment facilities in our city, one of them being the App Foundation, Addiction Prevention Treatment Program. And every week, 1,400 to 1,600 people come into our city to receive treatment. There are some less stringent policies that many people come from Waterbury and surrounding towns to get treatment, and it becomes an issue, and it's important for us to collaborate with them and with other treatment facilities so that we can both identify those who may be having problems and find better ways to get them the treatment that they need. That doesn't necessarily mean more arrests. That doesn't necessarily mean, vilifying these people, but identifying them and finding out why are certain subsets of people not responding to the programs that are being provided. And that only comes through collaboration. It may be through the church that may be dealing with them on one level. It may be through the drug treatment program. It may be through some programs that we've initiated in our department, like our LEAD program, which stands for Law Enforcement Alternative Diversion Program, where we catch people sometimes with low levels of drugs and we offer them a program rather than putting them in the judicial system. It is this type of collaboration that I think will help us to break the cycle of overdoses and addiction and help us to have a healthier community.
I don't want to be the bad guy, but generally that is my role. Unfortunately, the buffet has too many items left off the line, if you will. And that is that the population that we're charged and have been charged to engage here, such as those who've entered ED as a result of overdose, leave without the essentials to stay safe that they may have had prior to that admission. Now, what I'm saying is we have to understand, we hear a lot about recovery, but we have to respect an individual's right to use drugs and understand that drugs meet the needs of individuals on different levels. And and we're not always, as we engage people in these settings at their most critical. But not everybody operates on that end of the spectrum. So we have to have services, we have to have things available. When you talk about meeting people where they're at, you have to be able to meet people where they are. So what I'm saying is, upon release from the ED, why is naloxone not given to an individual? Not prescribed, why is it not put in their hand? An individual who may be an intravenous drug user, why can we not really simply make up a care package, if you would, and instead of just giving them that sheet of paper upon discharge saying, call me if you want to talk, because at that point, a person who is suffering from opioid use disorder knows one thing, that they might be sick at that moment and they don't want to be sick. So why do we not make sure they have the tools necessary to keep them safe? Because nobody plans on overdosing. It's just a result of how the drug supply has been, permeated by other substances such as fentanyl that we talk about. There are a lot of things we can do when we talk about public health responses that aren't popular, but they are public health responses. We have to begin to talk about SIFs. We're not talking about SIFs, and I'm sure Wasn't
Define
it.
Oh, I apologize. Safe injection facilities. The most popular, and there are probably about 100 of these globally, and millions of people have visited them. The most popular being Insight up in Vancouver, British Columbia, here in North America, has been in operation since I believe around 2003. They've had millions of people come through their door. They've had thousands of overdoses and not one fatality. And connected to Insight is On-Site. So as a result of these types of harm reduction approaches, there's an organic handoff to, because of, and again, how we engage individuals without any type of cookie cutter response, to really work with the individual, and we're able to organically make referrals that sometimes others don't. And so therefore we have to have relationships at a different level as well, because when we kick a door, a lot of times people, it's about operating in that moment. So some of the things, we have to do, and this goes back to the other also, are we're in the midst of an epidemic just unlike anything this generation has experienced. But we've really yet to change a lot of our operational methods. So we have to do some things that are really not popular and respond in a public health manner.
So I think when you're talking about, collaboration, there's the relational piece, which oftentimes include, leaders in different organizations and different institutions. And then I think you also have those same institutions that actually share. They share information, they share data, or they work collectively on policies, that, make things better. A couple of just observations, one of the issues that occurred maybe on the green was when we had some of our first responders there, they actually would recognize that a person actually felt appropriate after about 20 or 30 minutes of having taken the simple counterpoint, and yet they could not discharge that person home. For first responders, they're required by policy, by state policy, that they must have that person go to the hospital, even though they know that in this particular maybe instance, this person is probably fine. And so that, from a policy perspective, that actually inhibits and, if you will, it draws on a lot of resources. That we had multiple events that were going on in different areas, maybe the city, we would be pressed hard to being able to respond to that. From a data maybe sharing piece, we were fortunate in that, this California, or the Connecticut Department of Public Health, has a syndromic surveillance system that we were able to see. The problem with that syndromic surveillance system is that we can't actually see any individual in that database who's not a resident of New Haven. And so if we were thinking about the multiple folks who actually came from outside of the community, as we looked at that data set itself, we wouldn't be able to see those individuals who actually were coming into New Haven. So I think when you're talking about having true collaboration, I think that also has to include sharing data between different organizations locally, but also from a local to a state perspective.
Great. So I echo everything that you guys have said as far as, really collaboration is really important as far as figuring out how we can get people the services and meet them where they are. One of the things that I actually realized kind of sitting up here that I really love is the fact that we actually have naloxone in our emergency department that we actually are able to send people home with. And in part, I've gotten naloxone from Mark and actually from the State Department of Public Health. And so, that is something that we've been doing since August of 2016, and I think it's been a really important service for us to be able to offer our patients. And I think one of the things that I like about it is that it's really part of a continuum of services that we're able to offer. Our emergency department has had a project called Project Assert since 1999, and essentially the idea is we have health promotion advocates who are people who are from our community who have expertise in motivational interviewing, with meeting, with talking to patients, communicating with patients and providers, and they kind of are much like what TJ was saying, they have connections to all of kind of our local treatment resources throughout New Haven and really around the state. And so they're able to, ideally you would have an emergency physician or clinician, that, starts the conversation. But you were able to work as a team to kind of reiterate the importance of meeting people where they are, getting them what they need. And if it's treatment, that is amazing. A lot of times it's not treatment. And I think there's a lot of role for communicating the information that we hear and we know, even if it's not, necessarily people don't walk out the door and say, yes, sign me up for treatment today. It's important that they hear the things that we know from, our data sets and from our public health colleagues that, about the evidence for certain treatments and about naloxone. And even if we can get that message across, it's important to communicate that. The other thing that I wanted to say is that we have, I guess it's actually a continuation of that thought, which is one of the things that does is that helps reduce stigma associated both with drug use, with seeking help for drug use, and with accessing kind of harm reduction techniques, which are really important for meeting people where they are. We know that if you walk up to somebody and say, don't use drugs, that is not a conversation starter. But one of the things I'm really grateful for is, how can I help you today? Do you know about naloxone? Can we talk about a way to help keep you, safe until you're ready to enter treatment? These are the questions that I think are really able to help us make improvements, at least in a clinical perspective. The other thing is from a kind of coordination is really working collaboratively with Department of Public Health, with other state agencies around medical examiner's office, criminal justice system, around how can we know what's going on in other areas, and how can we really help understand what's happening with these overdoses and these deaths in our community. And I'm going to let Robert kind of talk a little bit more about that.
Yeah, in the spring of 2016, we were invited by the governor to come up with a plan for the state and how to respond to lower the number of overdose deaths. Our team, involving people from medicine, emergency department, school of public health, came up with a comprehensive plan. One of the key parts of it was to get the state agencies to collaborate and share data. That's been about the least successful part of our plan. We can't get one state agency to share data with others, nonetheless share data with us. So, this is a consistent problem that we're going to have to fix if we're going to have any impact on trying to understand the full scope of the problem and how we can effectively respond to it. But I want to point out more broadly that when we're talking about substance use disorders and opiate use disorders, we are talking about a chronic and treatable disease. Like most other chronic diseases, if you don't treat it, it does not get better. The difference, I think, with opiate use disorders and some of the other use disorders is that people do, if they can live long enough, get better on their own. Recovery, abstinence is a possible thing, but for most people, until that happens, and that's a lifelong process, treatment for opiates with agonist medications is key to their survival. Abstinence does not work in the short run for people diagnosed with opiate use disorders. So we have to do two things for people like that. We have to expand opportunities for getting opiate agonists for treatment for their disorder, and we need to provide them with naloxone and training in how to use it and how to respond to witnessed overdoses for responding to the emergencies when the treatment itself is insufficient.
So just because of time, I'm going to call on three of you for this next pair, and then the other three of you for the final pair. And it's just time. Otherwise, I'd want to hear from each and every one of you. So the questions are, what challenges does New Haven experience that may be different from those in other places? And I should have said this is going to be for Dr. Kennedy, Mark Jenkins, and Professor Heimer. And are there differences in responses to drug overdose in different parts of the country? Differences in experiences and responses to those experiences. So what challenges do we have that may be different from other places, and what are experiences from elsewhere that we can apply here? So it'll be Dr. Kennedy, Professor Heimer, and Mark Jenkins.
I think, one of the things that has made this, challenge, always, when you think about public health, resources always come up. When you're talking about resources, we've heard, a couple of them, one of them being just Narcan and having the availability of that. We were fortunate, both, a couple of weeks ago as well as a couple of summers ago when we actually had some of our supply come from the state Department of Public Health. So it was huge being able to put that into the hand of our first responders and then being able to coordinate that. And then also, we were in a role to sort of do training and do some distribution, not only within our staff, but also with some of the community providers. When you talk to some other agencies that are on the green, they may take approaches where they're prescribing it, but just that you can actually just hand it out. We've actually heard that, I mentioned several times today, it's easier just to put it in somebody's hand rather than just writing a script. And so I think being able to have more really access for that, where you don't have to be a clinician, you don't have to go to specific training. And then I also think too that one of the challenges when we think about perhaps in the state of Connecticut, that New Haven is, I think, a desirable place maybe to live, and as a result of that, it actually can be maybe a magnet for other folks that want to come here because we have so many resources, and we have so many assets. And so whether they're coming here for school, coming here for work, you can come here, just to spend the day, but also means we'll have other folks coming here for other things, including what actually happened a couple of weeks ago. So I think, being able to kind of address, the resource piece, but also, if you will, some of the higher demand that comes in from the outside. And then coordinating some of the resources that we actually do here and do a better job at that.
All right, thank you, Professor.
From my point of view, I think the biggest challenge in New Haven is that no good deed goes unpunished. We have a treatment program in New Haven, the App Foundation, that has expanded its services, its reach, with a very effective model of providing opiate agonist care. And in doing so, by bringing in more people for treatment, they have been criticized and called the root of the problem, when in fact, opiate agonist treatment is the solution for opiate use disorder. Their treatment model is a very broad, harm reductionist-based one, where people get the kinds of services they need and want instead of being forced a menu of services that chase people away from services. They are providing in-house treatment for people who are co-infected with hepatitis C. They're doing a really good job on training people on responding to opioid overdose, and yet the mayor of this town, insists on trying to denigrate what good they've done, and that is a real shame, and that is a real challenge. How are we going to get a better understanding into the head of the mayor that the expansion of services, that having more people in treatment is better than fewer people in treatment?
All right, Mark Jenkins.
Again, not one, I don't want to offend anyone. But you have Yale and you have New Haven. The two don't always necessarily go together. So from a community-based organization standpoint, a lot of them can't stand you because they can't get around you. So it's not about silo, it's about the castle that gets all the services and has all the resources, and you have agencies who really are versed at dealing with particular segments of the population that can't receive the funding to possibly carry out that mission. So from the outside looking in, it's not unlike other areas and organizations. There's been a lot of suggestions since the incidents on the green and ideas, things of like a drop-in center. I know just came out of someone who does a lot of work on the green through Cornell Scott. There's Hill Health, right? Something that we've just done in Hartford this past Friday on International Overdose Awareness Day, we opened up our first harm reduction drop-in center. So it's really a low threshold attempt, and we did it right in a hard hit population, which has its own set of challenges. But the idea is to really be able to reach people in their environment, in their space and time, and to offer some services and non-traditional hours, evenings and weekends, and offer a set of tools that have value to them, which in turn helps to build relation. And we work very closely. As a matter of fact, we wouldn't exist without DPH. And I'll shout out Mary Ann Bocelli is here with us today because she's done so much to make sure that this medication, naloxone, has.
We see you. Okay, thank you.
There we go. A lot of this wouldn't take place, or even, and when I tell you, they've had to take a lot of heat, because of the shit I've done. And trying to make sure, that this medication and these services are delivered into the hands of the people who need them most, when they need them. And that can be anything from syringe exchange, we do it all, safe sex kits. We make sure, like in the inner city, we've got Magnum condoms. They say, well, why Magnums? Because everybody has big egos. So but they also have currency. Everything we do, there is a reason. Everything is about reducing barriers. It's about reducing barriers and access to other avenues of care. And it's really just about keeping people alive.
Good, thank you.
Yeah, I just want to just maybe briefly, I do think maybe that the mayor is, she's supporting maybe harm reduction strategies. I think, part of the idea is just thinking about for some of our clinics, and actually maybe for all of them, are there just better ways of actually in terms of how the services are delivered, so that they're actually maybe reaching folks maybe that they intend to in the best way.
All right. So another block of questions, and this will be for Dr. Hawk and TJ Aitken and Chief Campbell. So what public health, community, or government effort do you feel has made the biggest impact on reducing overdoses, and why? And then how can we expand on this? And then a related question, if you had limited funds, how would you appropriate them to address the question, the issue? In other words, where should the bulk of efforts be placed? And examples are education, criminal justice, recovery programs, medication-assisted treatment, harm reduction. So they're related questions. What do you think has made the biggest impact? And then, given limited funds, where would you put the bulk of your energy? So I think you have the microphone, so Chief Campbell can go first, and we'll go to TJ Aitken and give Dr. Hawk the last word.
Sure. So, if I had, is it limited funds or unlimited?
Well, it's going to be limited funds. You see, the question reads unlimited funds, and then the answer is a little less interesting. So we're going to do if you have limited funds.
So with limited funds, I think one great thing about having limited funds is it forces you to pull more collaboration. And I think to echo what Dr. Kennedy was saying, one of the things sitting down with the mayor talking about these overdoses both a couple years ago and this year is talking about greater collaboration. I think that the greatest change that I've seen has come about through education, through educating along the lines of how Narcan and naloxone can be extremely helpful, about access to it, both educating law enforcement, first responders, and the larger public. I think there needs to be a lot more education. I think that education helps with the destigmatization. When people feel like it's an issue like a person having asthma or diabetes versus something that is to be put in the shadows, I think then more people can openly talk about it, and that education helps with it. So I would say I would use those funds for greater education, and not simply educating of the public, but educating the different silos on how to better communicate, how to better have the harm prevention programs directly address clientele who may not be responding. Maybe some recovery services can be applied. Everyone's trying to do the right thing. I believe that the hearts of everyone involved are sincere and they're looking to really save lives. But I think that sometimes we're reinventing the wheel. Sometimes I think that things that could have great traction, like many of the programs you mentioned, are not getting the traction that they need. I think a lot of times our egos and our arrogance as Americans gets in our way, because there are a lot of models and programs that internationally we can adopt and I believe save lives, but that requires a great deal of humility. New Haven is a city on a hill, and I see that what we're doing, including today's discussion, is something that is different than what I see happen around the country. There are a lot of places that this would not happen because they don't want to talk about the reality that this is affecting not just New Haven and large cities, but this is a national epidemic. When you have a country that has 5-6% of the world's population, but at some point we've used 90 to 95% of the world's manufactured opioids, how is that not a national epidemic? We're getting it little by little under control. We've seen reductions from the pharmaceutical standpoint of how much they've given out by 16-17%, but it needs to be much higher than that. And so I would say much more education and communication between the silos and educating the public.
Thank you. So if I had unlimited funding, the main thing with that, my thought process in that is like the diversification. I'm definitely for harm reduction, and I'm absolutely for medication-assisted treatment recovery. One of the main things that I think about though is like, so everybody's recovery process being different, right? Like abstinence-based recovery is the only thing that works for me, but that's not what works for everybody. And like finding that, and you know, obviously I didn't get in the getting people sober business. I got in the keeping people alive business too. One of the main kind of things I was thinking too when we were going around, I hear this word stigma, and I hear this word stigma, and like it's like a stigma, the big blue elephant in the room that everybody's talking about, right? So if I asked everybody in this room, whatever you're doing, stop right now, and whatever you do, do not imagine a big blue elephant. What was the first thing you thought of? A big blue elephant, right? Me too. So it's like being like a racial slur kind of thing. It's like the more we say these words, the more power we give to them. The more we say drug addict, the more power we give to that word. You know, the media can portray a lot of things. We see a lot of things. It's like the opiate crisis, dun dun dun. You know, and like. Also, I kind of wanted to jump into this other idea, and like when we promote recovery and advocate for recovery, it in turn creates prevention, and it in turn creates education. So I was raised by a father in recovery who ended up relapsing on opiates, and was then I used some of my resources to help get him into treatment. My younger brother, who is a recovering opiate addict as well, has been in recovery for 18 months, and I use my resources to help him. But what we do in recovery is we create leaders. And what's the main quality of having a leader in recovery is we create other leaders. My younger brother, who used to look up to what I have in recovery, now is a leader in recovery in the young people's recovery community. It's not, it doesn't, addiction doesn't discriminate age, race, class, sex, political affiliations, whatever. It doesn't really matter. It's affecting everybody. It's affecting our young people. It's affecting old people. It's affecting loved ones. I heard somebody talk kind of about sharing data, right? And we openly share data with just about everybody who asks for data. Kind of one of the main things in June, we had In June, we had seen approximately 1,500 people in the emergency rooms. We've connected 97% to care. 97% to some form of care or outside support, whatever that may be. So that's like kind of like the main thing. If I had unlimited funds, personally, I think community centers, and I think community centers is a great thing, whatever form of community center they may be, and meeting people where they're at and stuff like that is definitely important. Recovery coaching, treatment, obviously it could really go on and on. But the main thing about unlimited funds is the diversification of said funds.
Great, thanks. And so actually, kind of following on that note is one of the things that hasn't really come up today is insurance and ability to access recovery. And so I would actually say, I think one of the biggest things that the government has done around not necessarily preventing the overdoses from worsening, but I think Medicaid expansion is huge. And I think the ability for people to, not just in Connecticut, but across the country, to have insurance to access treatment, whether it be opioid agonist treatment, which we're lucky enough in New Haven to have programs that do provide sliding scale, but that is not the case in other parts of the country. And whether it's for that or for inpatient treatment or for other services, for psychotherapy, for intensive outpatient treatment, insurance is really, unfortunately, an important part of being able to access that. So I think that's an important thing that has not come up yet today. As far as if I had unlimited funds, I think expanding access to treatment. The criminal justice system hasn't really come up that much today, and I think we have a group of individuals that we know have an extraordinarily high rate of opioid use disorder who have an extraordinarily high rate of overdose and death upon release. And Dr. Maurer here's on the front row, and I just want to point her out. She has been doing really amazing work as far as trying to really bring recovery to our high-risk populations in the criminal justice system.